Thank you all so much for joining this breakout room. My name is Egypt Evans. I'm the Director of Operations at Full Circle Health Network. And today we're going to be talking about how we can leverage partnerships to strengthen our communities through CalAIM. I'm going to dive more into Full Circle and who we are, but first, just to share a little bit about me. I have been with Full Circle since the beginning of November 2023 um, in the role of assistant director of operations and director of operations. Before that, I was a director of programs for an LA-based nonprofit that was really focused on early childhood mental health, early prevention and intervention services, where I led the Los Angeles Department of Mental Health Innovations Project and several ACEs Aware projects. I also have experience working with behavioral health managed care operations and health strategy development across hospitals and health systems across our country. So today, what we're going to cover is really focused on three buckets and kind of three main goals. The first is identifying opportunities that we can leverage to really support the Medi-Cal reforms through CalAIM and how we can support our members through prevention services utilizing these services in CalAIM. Second is how Full Circle as an organization is acting as a community hub model and how that can really impact the link between child welfare involved families and CalAIM. And then third would be addressing some of the current barriers that we're experiencing with engaging this population in ECM and other CalAIM services, and some recommended action steps that we have to share with you all to partner and collaborate on that we've been able to identify through our work. Before I go further, I'll just say this. I have limited view of the chat. I'm definitely open to take questions throughout, and I believe we have time at the end as well to take questions. I'll be sure to leave enough time at the end for that. But George or anyone, if you could let me know if any major questions come up in the chat along the way, that would be helpful so I can keep an eye out there.
For sure, I'll do that for you.
Thank you. Okay, so just to start off with a couple of data points around this. I just want to hone in on a couple here. There are 4 data points on this slide, but specifically looking at the 9 and 10 child welfare involved families being below the income limit for Medi-Cal eligibility, that really just gives us an idea of how many families we can potentially serve through enhanced care management. There is a lot of opportunity here if we're able to kind of leverage these partnerships and collaborations in the best way possible. Also looking at the 1 in 3 number on the right side of the screen, 1 in 3 children in foster care under 5 years old. So that really presents an even more unique opportunity to do these prevention and early intervention services with our smallest kiddos in the population to really be able to set them up with some buffering supports earlier in life to be able to help kind of the full trajectory of their lives moving forward. Sorry about that. I lost my, okay, here we go. Okay. So this is a visual to just kind of help set the scene a little bit further on data and numbers and what we're looking at when we think about who we can potentially serve through enhanced care management before they're escalated through the system. And so what we have kind of circled here in red are the number of individuals that are actually staying at home with some monitoring. So there's almost 4,000 in California that we're seeing on a monthly basis that are in this situation. And so if we're able to really serve these members that have that monitoring case open, we can hopefully stabilize the entire family to avoid any further escalation. However, in order for us to engage with these members at this stage, we do need the right pathways to reach them, to engage and educate them on what these services could look like. So we have a unique opportunity, and the folks in this room, based off of who I saw in the chat, there's a really good diverse group of people here from providers, managed care plans, and other areas of the continuum of care. We all have a really unique opportunity to be deeply connected through this work and identify shared goals and intentions to support our children and youth and their families. But we really do need to have a connector at the center of that to help facilitate the work, which is where Full Circle comes in and where we are positioning ourselves to be able to support that collaboration. So I'm going to dive into a little bit about who Full Circle is and what we offer, and then zoom back out to the child welfare involved population of focus and the way that we're approaching our work with that population in particular. So first is who we are. Full Circle, we are currently the largest integrated network of community-based organizations in California. And we are delivering coordinated care through CalAIM services to children, individuals, and families across the state. We're currently working with 90 providers across about 40 counties in the state, and our plan is to be statewide by the end of this year. And we were born out of the California Alliance for Children and Families, which many of you may be familiar with as an advocacy organization based up in Sacramento, California, that does a lot of lobbying and engagement work at the state and federal level to advocate for children and families across the state of California. Full Circle was launched in the beginning of 2023, and our work has really expanded since then to include community supports, community health worker services, as well as ECM. So what we will discuss today is really focused around child welfare involved individuals, but we do serve all populations of focus, specifically for children and youth in CalAIM. As you all may be aware, CBOs are a really essential component to CalAIM reform. They have been kind of set as the ideal provider to deliver these services. And as you all know as well, managed care plans are required to contract with these CBOs to deliver these services. The reason why they're so important and so essential to this work is because they are trusted messengers of the community already. They're embedded in the community. They have identified the needs of the community. They generally have shared experience or members of their staff with shared and lived experience with the community. They have diversity that reflects the diversity of their community. And also, they've developed culturally sensitive and appropriate care service lines to be able to serve their members most appropriately. But the collective challenge that comes up around this is how can these CBOs and nonprofits that are embedded in the community become a part of Medi-Cal networks to best align service delivery? And that's where Full Circle has come in to support them. So our organization is really built for and by our community-based organizations. And what we do is we really focus on empowering our providers to focus on all the aspects of well-being for their clients and really take the lead in developing those care teams and identifying the best ways to engage and support members through CalAIM services. We do this through three major kind of buckets of work, which is number one, partnership. So we partner really closely with our providers, and we really think we walk alongside them instead of in front of them to identify quality improvement, what care should look like, what engagement looks like for CalAIM services. We also offer a really unique and robust platform that includes technology solutions and claim solutions for our providers to be able to support their operations while they're able to really take a focus on delivering care while we really focus on the administrative components like documentation, other note-taking requirements from the managed care plans and DHCS requirements, and again, that quality oversight and audit management. Additionally, since we work together as a network, we do have several providers that are able to learn from each other and not just from Full Circle, but really bringing our providers into spaces where they can share experiences, discuss different care approaches that they've developed that are best practices, and really just be able to learn from each other in real time. We work with all sorts of CBOs, and as you'll notice here, this really covers the continuum of the populations of focus from DHCS across CalAIM. So this list includes specialty mental health providers, justice-involved providers. We contract with family resource centers, early childhood mental health providers, foster family agencies, and several more birth equity providers. But what all of our providers have in common is that they all have a deep experience specifically working with the children and youth population. So in order to contract with us and really start working with these members, we do really thoroughly vet our providers for that experience in working with this population in particular. As mentioned briefly, our core services, our mission is to reduce the administrative burden for our providers. We want our providers to focus on delivering care. That's what they do best. That's what we want them to put all of their energy into. And so the reason we exist is to allow providers to, again, focus on that care piece and not be burdened by all of the administrative work that it takes to contract with a managed care plan and to maintain that contract over time. As it mentions on the slide, we're not just a clearinghouse or a third-party administrator. We do the administrative pieces of this work, so that includes training, the initial contracting, quality management, oversight, claims administration, as you see here. But we take it a step further with our providers and ensure that the administrative components are there and in place for them, but also we help them with things like program development of pipelines to identify appropriate referrals, helping them identify the best process for identifying staff that might be best fit. So it really goes beyond just administrative function, but really helping them programmatically identify what they can leverage internally to be a successful CalAIM provider. So who benefits from our work? We are really looking to be a benefit and a resource to youth and families. Of course, at the core of all of this is we want to ensure that our youth and families across the state are empowered and are receiving the services that they need to thrive and grow. Community-based organizations are really a huge beneficiary of our organization's work because they are, again, able to focus on that person-centered service delivery while also accessing cost-effective administrative infrastructure through Full Circle. And then our health plans, they also benefit from contracting with Full Circle because contracting with one organization gives them access to a whole network. It also ensures that their documentation, their quality oversight, and then audit management is very consistent across the board with all of the network providers that they have access to through us. So it really does help streamline things from all aspects of the CalAIM service delivery model. So that's Full Circle and just a little bit about who we are and what we do. We do have contract with several managed care plans across the state right now. And again, we're planning to be completely statewide by the end of this calendar year, which we're very excited about. So we're constantly ensuring that we do have contracts with all of our managed care plans. We have them with both large managed care plans like HealthNet and Kaiser, and we even have kind of more regional, smaller health plans like Santa Clara Family Health Plan. We have IHP and Inland Empire Health Plan on deck, as well as San Francisco Health Plan. So we are really looking at kind of all counties and all aspects of care for our providers to be able to serve the members in their community through us. So moving into specifically the child welfare population of focus, as you all can imagine, there have been some barriers to engaging this population of focus. And we've done a lot of work over the past year to identify those barriers and start delivering and developing strategies to be able to support these populations despite those barriers. So just a snapshot of the current state of ECM delivery. Right now, less than 1% of children in youth statewide are receiving ECM. That's overall, so not just the child welfare population, this is everyone. Um, However, although the enrollment is steadily increasing, we are still seeing that the enrollment in larger plans and those larger dense counties like LA, where I'm based, we're not seeing a whole lot of engagement there, so that we are seeing even a lower enrollment rate in those counties. Um, as we look at the child welfare population of focus in general, we're seeing about 4% of that population receiving ECM services. And we see, so it's a little bit higher than the average, but still very low when we look at the numbers. 1,700 out of 42,000 is really just a drop in the bucket, especially when we think about the fact that most of these members in child welfare involved situations are eligible for enhanced care management or other CalAIM services. So, despite the need for members and the interest in serving them from community-based organizations, we're continuing to see the challenges in connecting this population to services. And based off of this data that we've been able to gather, Full Circle as an organization, we've identified some goals to support the growth in CalAIM utilization among specifically the child welfare population. And I'll be highlighting a few of those goals during our conversation today. So the first goal that we've identified that may be really a good opportunity for us to leverage is linking families to ECM and CHW service wherever we can. And a prime entry point for this is through the differential response system. So we look at this estimated California population, we see about 100,000 children or youth are annually calling into this differential response line. And so ECM could be a value add to prevention for members that may be calling into these lines. These members may not ever make it any further into the child welfare system, which is we hope that that is the case. However, we do see that when members are calling in, there's usually a need and interest in receiving a resource or support, and the social worker or other worker on the other end of the line also generally has expressed that they want resources and toolkits to be able to support these members. And so we see ECM as really being a place where we can engage these members that may have screened out of child welfare services to be able to support and stabilize the family before it escalates into an actual case. We also noticed that with the differential response, it could be an option to assign, um, a ECM provider immediately, or CHW provider immediately if we have the right pipelines built out. So this is one of those places where we could easily bring in an ECM or CHW worker to support the family and ensure that that case does not go further as far as escalation in the system. Another entry point that we've identified is linking families that may have family maintenance cases. So right now, what we're seeing, as you can see these numbers here, there's about almost 10,000 in a no placement family maintenance case, so that the kiddos are still at home. And then we have about 5,000 in post placement family maintenance. So a couple of examples that are shown on this slide give wonderful examples of how we could potentially engage these members in services, whether they're in pre-placement or if it's post reunification with their family. But in either case, these services would be a really great opportunity to dig into the prevention work with families who haven't experienced removal at the front end, or to prevent reentry for those that have already completed the reunification process. One note about this, and it's noted here on the slide as well, but since these members are not identifiable by a Medi-Cal aid code, they're not assigned an aid code. This does require a direct referral to be made, similar to the previous slide. So these members that are in the family maintenance cases are still definitely eligible for ECM. They could also be eligible for the new presumptive eligibility that went live 1/1, which allows us to start working with a member at least 30 days before their official authorization comes through, if they are in a specific subset of populations of focus, which thankfully child welfare involved individuals are in that. But this would really just create a really beautiful pathway for us to be able to engage with members and families to support that either prevention or support that restabilization once reunification has occurred. So in order to increase the utilization of CalAIM services, we really need to educate and equip our CBOs and other trusted community providers with information on what these programs actually are and how to refer. And what we've identified is that education and awareness is a huge barrier overall to being able to enroll members in services. And so our approach at Full Circle to this has really been aligned with what was published in this article that goes along with this visual that we have here on the deck, which is the RAND conclusion from RAND Corporation. It was published last summer, 2024, and it was focused on how the title of the article was published in the key findings and recommendations for implementation of CalAIM. And this was from or through the ACEs Aware practice grant work. So this visual is really just touching on and showing the entry points that are most effective for CalAIM services. And what we've identified through our practice and also what has been shown through the research that's been done in the short period of time we've had so far is that the most effective approach for engaging members and services is through a trusted provider. We know that we receive MIFs and referrals from our managed care plans each month that we're required to do cold calls and outreach to engage in services. And that does result in some enrollments and some interest from the community. However, we see such a huge, almost 100% enrollment rate when a member is referred by a trusted provider. That trusted provider could be their local community based organization where they go for food resources. It could be their primary care physician. It could be their therapist. Whoever it is in that person's life that they're really connected to and trust, if that provider thinks of ECM or CHW services as a really useful tool for them to be able to receive care, and they educate that member on what it is and refers them in, we see a huge success rate with members actually engaging. Some drivers behind low enrollment, which we will dig into for each, um, are number one, foster children statewide are generally still not enrolled in managed care. Most of the child welfare involved individuals we see are either in fee for service or they've been moved into fee for service when they're in the system and remain that way once they are completed or close out a case. The second driver for low enrollment we're seeing is that, again, as I've mentioned, ECM and just CalAIM in general is relatively still new. We've been doing a lot of work behind it for the past couple of years, so it doesn't feel as new for us, but it's still relatively new and unknown among child welfare staff and also just the community at large. Another driver that we've identified behind low enrollment for CalAIM services and ECM in particular is that the referral pathways are not clear. We know that social workers and public health nurses at the county level are very busy. They want to support their families, and also they need simple and clear referral pathways to be able to do this. So we're really looking at how to deliver and support them through that through really clear and simple pathways. Additionally, a fourth driver for low enrollment are that ECM networks usually don't include agencies that child welfare agencies recognize. So we know that our child welfare agencies have really trusted partnerships and engagement with certain organizations in their counties, their cities, their networks. And so if our ECM providers don't reflect those providers they are used to working with and trust to refer their members to, there's a disconnect. And so we really want to try to align those provider lists. Additionally, there's a fifth driver around inaccurate contact information, which we'll discuss more about in a few slides, but just wanting to touch on this briefly. With this population, we know that there's a chance of them moving around quite a bit. Numbers change. The folks that they are in the care of changes. And so we are identifying pathways to be able to support these members and stay connected with them. And then the final driver is just lack of clarity around consent. We know that some of our programs and some plans have specific requirements around consent, and it can be really confusing for our providers at every level, at the county level, CBO level, to understand what the consent is for CalAIM services. And we really want to demystify that and explain that further for our providers to really streamline those referral pathways. So diving into the what and the how. So we talked about what's driving some of the low enrollment for the child welfare population of focus in CalAIM, but we really want to talk about what our recommendations are based off of what we've been able to identify and work through with our managed care plan partners and our CBOs. So again, the first driver that we talked about was that most foster youth statewide are still not enrolled in managed care. Through managed care plan enrollment, they wouldn't only have access to ECM and CHW services, but also many other supports that having a health home of sorts provides, which could include receiving services like community supports, So there's 14 community supports that are currently live with most of our health plans, including housing resources, getting connected to housing, being able to sustain their housing through education and support from a housing navigator. There's also medically tailored meals to support members with chronic conditions. Through their managed care plan, they could also receive access to things like wellness support groups, transportation services, and other health encouragement services, to name a few. So we're really looking at where those counties where managed care plan enrollment is optional, really encouraging child welfare agencies and social service departments to maintain children and youth in their managed care plan as much as possible. And kind of returning them to those managed care plans once reunified with their families, if that does occur. Around driver two, which was that ECM is relatively new and unknown, really education is the main component around this that we have to look at. So education and awareness at every level of the community. So it's educating our social workers, resource families, public health nurses, and the community at large, again, through ECM. Just that awareness that this is an available support to their families and something that they can leverage that will not impact their other healthcare services, will be really important to increasing enrollment. Something that Full Circle and myself in particular have spent a ton of time over the past several months on is going on what we're calling a road show with one of our managed care plans, Kaiser. And so Kaiser is across 32 counties in the state of California. And so they have a really unique opportunity to be able to get in front of several county social worker groups across these 32 counties to educate and share how ECM works, how it complements the work that they're doing, and how it really can support them and their families. So this roadshow has started last summer, end of summer, early fall last year. And what the intention of these roadshows is, again, education and awareness. So the first step we usually take is going through and explaining what ECM and CalAIM services are, how they work, why they were developed, who's providing them in that county, and then we dive more into what this actually looks like. So this is an example of a case study that we share with our county social workers and public health nurses in each county across the state of California. And what we try to share and get across through these case studies is just a little bit of a background story and then getting into how ECM works and how it, again, not replaces, but really complements the work of the county social worker. So for example, this is a case study on a non-minor dependent that's in that transitionally aged youth age group. Her name, for the purposes of this example, is Joe. She's currently in extended foster care at 20 years old as a non-minor dependent. She currently lives in a transitional housing plus program and attends community college. She does have transportation through the public bus system, and she has the goal to complete a bachelor's degree, and with the intention of becoming a teacher. So she is currently suffering from frequent panic attacks and reports a constant feeling of anxiety, and also has acknowledged that she does struggle with some nutrition and healthy eating to cope with her anxiety. She also has some contact with her birth family, but she says that she does not have full kind of addressment of her prior trauma exposure. And so she mentioned that due to her trauma history, she also struggles with developing trusting relationships with others. So there's kind of a social component there. So once we kind of share what her background is, we look at the presenting needs, which I won't go into too deep, but I really want to focus in on this role of the ECM care manager. And these are the really practical points that we try to drive home and share with our providers and partners as to what ECM can do for not just families, but even our independent TAY. So the role of an ECM care manager, some of the benefits that ECM can bring to Joe is helping her to establish a PCP and connect her to a therapist. It could also be teaching Joe about the benefits available through her health plan and how to navigate them, engaging with her on connecting with her community college counselor and researching what social programs may be available to her at school to engage in those social experiences and help kind of build her social skills up around her anxiety. Then also it could be helping her identify long-term housing programs. She will be transitioning out of this transitional housing plant program soon. She will have to, and so having that support in place to help her identify long-term housing will be really helpful long-term for the trajectory of Joe's life. Also, what's in the lead care manager's purview of care is helping her actually make reach that goal of becoming a teacher. So helping her identify and navigate what that transfer might look like to a four-year college and making sure that she's feeling empowered to really take control of her education and move forward in her goals. So this is just one of several case studies that we've developed at Full Circle to show the impact that a lead care manager and enrollment in enhanced care management could have on a family or on an individual member, and how again it really complements the work of the child welfare social worker and can support the member beyond their engagement in the child welfare system.
I'll take a minute to pause there. Egypt. We did have a question going back to the drive recommendations. We had Natalie from Children Now ask. So that I've heard that one reason that foster youth are enrolled in fee for service is because kids move counties so much and that it's easier to keep continuity of care with fee for service rather than managed care, which can change from county to county. Do you have
Mm.
thoughts on how to address that issue?
Yeah, thank you so much for bringing that up. I think that's a something that we've also experienced, and we, of course, we don't um, tell which members to enroll in which managed care plans. However, if we look at some of the larger ones like the Kaisers and the health nets, we know that they have really wide county coverage. And so even if a member, for example, we had a child welfare involved member that moved from Northern California down to Southern California to a completely different region, because they had that Kaiser coverage, they were able to maintain their benefits. Of course, they had to change their providers and their PCP engagement, but their CalAIM benefits were still in place because they had that managed care plan coverage that had several counties under their contract. So again, we're not encouraging any one managed care plan over the other, but there is benefit to being enrolled in one that does have multiple counties that it covers.
Thank you.
I think there are a couple of other, I can just take a pause here. We have time for questions. Were there any others in the chat?
Another one from Nicole said, do these service providers that are identified to support an individual to reach their goals have to be part of the Full Circle Consortium?
Great question. No, they absolutely do not. So I will share a little bit more about that. So for particularly, I'll call out Kaiser separately because they have a different model, and then I'll zoom out to the rest of the managed care plans across the state. So Kaiser in particular has adopted a what they call a network lead entity model, which basically means they're not contracting directly with any providers. So they only contract with three organizations that are like us. So Full Circle Health Network, Independent Living Systems, and Partners in Care. We are the three network lead entities that then contract out with CBOs that are delivering services. So for Kaiser, a ECM provider would have to contract with Full Circle to serve youth. However, for all of the other managed care plans, they kind of have a two-way um, process for contracting. So all of the other managed care plans, CBOs can contract with directly, or if they're interested, they can also contract with like Full Circle or another community hub um, that is kind of absorbing that administrative component for them. So it's not a requirement for all managed care plans. It is a requirement for Kaiser. But there are plenty of opportunities for CBOs to contract directly with the managed care plans as well on their own. Are there any other questions in the chat or anything else, George?
I just want to highlight a couple comments. We had Monica from Butte County say that she completely agrees that referrals from trusted providers make a big difference. You know, Joni from Parent Partner, that in Contra Costa County, I've had clients that have had wonderful experiences with their public health nurse and with ECM. I'm surprised that it is underutilized as it is a huge benefit to our families. And then we had another question come in from Crystal, is that some counties only have one MCP to choose from, which prevents the youth from being able to receive continuity of MCP and ECM services when they move to a new county that does not use the same MCP. This is creating major problem for small or mid-sized counties to access ECM for youth who are not stabilized in housing and moved often. What is the progress in addressing this challenge statewide?
That's a great question, and I think it's one that we're still grappling with at Full Circle. We have been kind of talking with um, several systems and our managed care plan partners on how we can best collaborate. This is definitely not the end all be all or like a full answer to your question, but something that we have tried to do since we are trying to be statewide is whenever possible, when our providers are working with us and if they have a member that changes health plans, what our model is a warm handoff at all times. So if we have a provider, I'm going to use two random managed care plans for an example. If we have a member, and this is probably an extreme example, but we have a member that's in San Francisco Family Health Plan or San Francisco Health Plan, and they're working with provider A. And the member says, I'm moving to Santa Clara. Um, I'm moving to Santa Clara next month, and I still want ECM services. What our providers can do through Full Circle is they can come to us and say, hey, I have a member, they want ECM still, but I can't serve them because they're moving from San Francisco to Santa Clara. What can we do? Since Full Circle has a connection to both managed care plans, we're able to go to our San Francisco providers. First, seeing if our provider number one, provider A, has coverage there. If they don't have coverage there and they absolutely can't serve them, what we will do is complete a warm handoff, which includes an introductory meeting, a case coordination meeting. Usually takes 2 or 3 meetings to really get everything in order for the member. But we do try to facilitate those connections so that the member, although they will have to switch their managed care plan potentially, and their provider for ECM, they're supported through that process. We also provide our network with job aids on how to help members transition their managed care plans, how to help them re-enroll in Medi-Cal if that coverage is lost. So although it's not fully addressing the issue of having to switch, it does help them with the process of being able to continue receiving care. And I happened to see, George, I had the chat up because I was trying to read the question along with you. I see the question, would their lag time be in service? So usually it takes 30 days for the managed or Medi-Cal to switch over the managed care plan coverage. We track that really closely and do our best to ensure that they can continue receiving services until the end of the month that their current managed care plan coverage goes through. And then ideally, if we're able to catch this early enough, we're able to shorten the lag time between like 2 to 3 weeks before they can start receiving services from their new provider. Obviously, that varies case by case and like when we catch it and when we're able to get them enrolled. But that's generally the process that we use to try to reduce that lag time in services. I will say one thing too, if we don't have a connection or a contract with the managed care plan in the county that they move to, we do have contacts there. So we really try within our system at least to engage those managed care plans and try to fast track as much as possible and support the member through the process of getting connected until they're officially set with a new provider, whether that's a full circle provider or a provider outside of our network. But I definitely agree with you, Crystal, that it's a really, really big undertaking and big issue for all of our kiddos. But we are doing our best at Full Circle, at least to try to submit or support families through that process as much as possible. Any other questions before we move forward? Thank you for the engagement. It's helpful to talk through some of these questions. Okay, if not, I will go forward, and then I think we should have time for questions at the end as well. So I'll keep going. If any major questions come up again, George, feel free to interrupt me. Um, so looking back at our driver three of low enrollment, which is that social workers and public health nurses need those simple referral pathways. We know that they're busy. They have 1 million things going on. They have high caseloads, and we don't want to overcomplicate this process for them. And so, what we're recommending around this is really just developing those simple referral pathways and training them on how to refer their members in for CalAIMS and ECM services. This does require the managed care plans and counties to work together to ensure that they're in alignment, which I know is a big undertaking, and something that Full Circle is trying to drive forward, and increase those connections and increase those conversations, and as much as possible add our voice to the table to ensure that the member and CBO voice is there as well. But what we've developed as far as just one example of what this could look like is how potentially a social worker or public health nurse could complete a referral. We have several entry points. We try to take that no wrong door approach for referrals. So providers can refer through us, they can refer through one of our providers in the community. But for this example, we are going to go through the example of a social worker or public health nurse that's working with the family to make a direct referral to an ECM provider. So what this might look like is number one, the social worker might explain and educate the parent or caregiver on ECM and its benefits, making sure that they're seeking that verbal consent and permission to send a referral to a local ECM provider. So it might be one of their providers that they also refer their members to for mental health supports, but they now know that that mental health organization is also an ECM provider. So it's someone they know, it's someone they trust, they have a good relationship with them for referrals. So once they get that member's consent to submit the referral, they would go ahead and submit that referral to the trusted ECM provider. Once the provider receives that referral, they would immediately connect with the parent or caregiver. Once again, explain ECM to the member to ensure that they're interested. And then from there, they would submit their referral to the managed care plan. If they're one of our providers, they would submit that referral to us and we would go ahead and process that for them. Since these individuals and families are eligible for presumptive authorization, once they submit the referral to Full Circle, we work to verify eligibility and assign the member back to them within 72 hours. So if the member does meet those presumptive eligibility requirements, which is they meet one of the populations of focus for presumptive eligibility, and they are eligible with the health plan as shown on the portal and on the Medi-Cal site, we will immediately assign the member back to them so they can start working with them while the health plan reviews the authorization and approves it. Once that authorization is determined, hopefully it's approved. Then from there, the lead care manager would continue with their service delivery. So they would develop the ECM care plan and goals. They would, with written permission from the member, communicate with any existing providers, including that public health nurse or social worker that referred them in the first place. So really trying to keep the original referring party, if they want to be, included in that care plan and included in the updates around the authorization status. Did they get approved? Did they not get approved? If they did get approved and they're going through the process, what are the care plan goals? Are they aligned with the goals what the social worker has for the member? Are there any components of like the health and needs assessment, like the physical section that requires that medical support and medical attention? Are those things that the lead care manager can potentially build into the care plan and assessment? So really trying to not just be siloed, but again, lead care managers are coordinating that care, and that includes coordinating and supporting the social worker and public health nurse with that member. I see a couple of chats coming through. I can't open them, but George, is there anything in the chat that we want to address now?
Do you have a list of your providers? And then also, could initial referrals be submitted to FCHN if the local ECM provider is unknown to the social worker or public health nurse?
Yes. Can whoever, I will check after this, can whoever ask for the full list of providers, drop their email in the chat so I can share it. And then um, additionally, and maybe if you have a specific county that you're looking for, if you can share that too, that would be helpful because we have quite a few providers. So I'd want to share the ones that are most relevant to you if that's something that's of interest. Um, as far as the second question, yes, initial referrals could definitely be submitted directly to Full Circle. I will drop that email in the chat, but what we've done, and I was going to share this a little bit later, but I can share it now. We've started to develop some referral pathways with local county social workers and local county child welfare offices. So, for example, right now we're starting a pilot program with LA County. They have a small pilot program out of one of their offices here in LA focused on child welfare engagement with ECM. And so we do have a general referral inbox where anyone can submit a referral to us. And what we'll do is we will screen the member, identify the managed care plan affiliation and verify that, identify the best provider for them based off of location and need, and then circle back with the referring provider to let them know who that provider is, connect them if they need or want to be connected to the lead care manager, and kind of start delivering those services to the member and ensure that connection with the referring party and the assigned lead care manager. So yes, if there's not a local ECM provider that you're connected to or have a relationship with, you can definitely refer through Full Circle and we can get it to the right place. So jumping back into some of our drivers and our recommendations around increasing enrollment despite these drivers for low enrollment. So if you remember, driver number 4 was around ECM networks not including agencies that the child welfare agencies recognize. We definitely see this as an opportunity for education and for growth. So for education, we believe that counties should be sharing their trusted provider list with MCPs in their county and encouraging their providers to become ECM providers if they aren't already. Contracting with Full Circle does give providers the access to serve members through different managed care plans depending on their county coverage. So especially for providers that are serving multiple counties, it's we believe we're a really good pathway in because you get access to several managed care plans at once through the same platform. But also something that we do a lot of on our road shows that I mentioned earlier is just asking and having conversations with our county social workers and our other county child welfare staff is who are you referring to? Who do you trust? Who are those go-to providers in your community that you hear good experiences about? Who your members have good reports about? Who are those people? And finding out if those providers are already delivering ECM or are well positioned to deliver ECM, how do we get them involved and how do we get them engaged to ensure that you have those really clear pathways for referrals and also so that CalAIM and ECM is a bit less confusing and not as daunting because you know the providers that are delivering that care. For driver number 5 around having inaccurate contact information, this is like a really complex one and something that we're going to have to work through this many different ways and continue to identify best practices around it. But what we're really looking at is how much this requires stakeholder engagement around sharing contact information because we know that this is a potentially a transient community. Numbers change for all of our families in the overall Medi-Cal population quite a bit, but specifically for child welfare, we see a lot of that change and just incorrect information. And so we are looking at ways at a systems level to be able to support the following of members updated contact information be reported to the managed care plan and to the providers. But really, this does just kind of take us back to that slide we saw on the best pathways into ECM and CalAIM services in general, and that's through those direct referrals. The county social worker, 9 times out of 10, is going to have the updated information because they have that connection to the provider. They know, or the member, they know who the member is. They talk with them on a regular basis. They know when their information changes. And so if that provider is referring them in, then we know that our ECM provider will have that contact information that's appropriate versus the cold calling component of our outreach that's required by CalAIM a lot of the time does not result in successful encounters because we don't have the right information. We're not able to connect with the members. So again, just kind of driving that point home around the importance of those direct referrals from trusted providers of the member. And then finally, the lack of clarity around consent for driver 6. We talked about this a little bit as on the last slide about obtaining consent from the member, but this is a question and point of clarity that has come up a lot during our conversations with child welfare agencies, which is just identifying what consent looks like for ECM and also what impact or non-impact that ECM has on other members' services. So this really requires education around the fact that ECM does not require any special written consent from a member. If a member verbally consents to services and that's documented, we're able to move forward with the referral. And as mentioned on that last slide on the referral example that we shared, the social worker or provider that's referring the member will get that initial approval or verbal consent from the member. But we do a second level for the member once they're assigned to a lead care manager in ECM to ensure that they agree to enroll, just to be sure that we're hitting that consent requirement appropriately and that the member hasn't changed their mind. Something else that's a little bit related to this is, again, just kind of thinking about and educating the community on the fact that ECM does not impact the members' other healthcare services. A lot of times when we connect with people, whether it's members or providers, they think, if I opt into ECM, does it impact my other Medi-Cal benefits? Does it impact my ability to get these other services through my managed care plan? And so just educating them on the fact that this is an additional benefit to their current managed care plan services and not a replacement of anything is another really big component of this education that we think will help and engage more members in services. So in conclusion, we know that meaningful system changes take a long time to materialize, and some of the recommendations that we've shared during this deck and during this conversation do take time and takes a lot of stakeholder engagement and willingness to come to the table to make some changes. But despite knowing that it does take time, we're really, really focused on the urgent need for our families and children across the state of California to get connected to services that they really need. CalAIM is intended to support these families, and there are hundreds of CalAIM providers across the state that are ready and willing to support members, but we have to help to drive those connections together to enable members to actually receive the services that they need. So to be successful in this, we all really have to come together at the table to identify how we can best serve these families and connect them to these really important services with the shared goal of developing happier and thriving families across the state of California. And so I appreciate you all's time today going over some of what Full Circle is doing around these efforts. And this brings us to the end of our presentation, but I am happy that we have some time for any additional questions or just conversation around the child welfare population in CalAIM.
Yes, thank you. Thank you, Egypt. Feel free, you guys, to come off mute, turn your cameras on, raise your hand, or put it in the chat, and we'll have Egypt answer your questions for you.
I have a quick question if no one's coming off mute. I can't see everybody. I'm sorry. This is Amy from San Diego. I'm with the YMCA. And I just had a question. First of all, thank you so much for this presentation. Absolutely amazing. And love the kind of questions and conversation that are coming from the group. My question is if folks are aware of any county that's leveraging CalAIM community schools, multi-payer fee schedule, and children and youth behavioral health initiative dollars, and FFPSA, because in my mind, all those funding streams are really intended to support children, youth, and families. And it doesn't seem like any of them alone are sustainable. Reimbursement rate for community health worker is like, it's nearly impossible. So just wondering if each of you or anyone else on the call has any suggestions or recommendations, or are interested in thought partnership. My email is in the chat. I'd love to connect. So thank you.
Yeah, I'm thinking about the counties we've worked with so far. So it's a conversation. I think it's on the minds of a lot of people because, as you said, all of those funding sources are very closely related, and some of them overlap a little bit and some of them conflict with each other, which is a whole nother topic for discussion around aligning those in the way that they are, the way that they work and the way that they're outlined for people. But I don't think I have any specific examples of that actually working. So I'm happy to connect with you further on that offline, but I don't have any specific examples right now. I'm not sure if anyone else does. I'm taking down emails from the chat just so you all know. While I take down the emails, I'm going to try to do this simultaneously, but I saw another message in the chat from Brittany that spoke to or asked about, I'm sorry, I'm just reading as I go. So it says, we're seeing an increasing cohort of children entering foster care with complex care needs. Their families have seemingly exhausted all of their resources and get advice to abandon their children to foster care to get help. As you know, this is often no relief. There is often no relief for the issue. How can our community pathway and other prevention providers use ECM to support families in this predicament upstream without increasing their exposure? This is a wonderful opportunity, I think, for enhanced care management to step in and support, to stabilize and really like resource the families, because something that we ensure our providers have access to and are well versed in before bringing them on as a provider is knowing what resources are available in the community. And it's not a referral program. It's a warm connection. ECM is authorized for a year. So it really allows the ECM providers to step up and walk alongside the families for a full year to ensure that they're connected and receiving the supports that they need. Not just that they got a referral and call the provider, but that they're actually engaged and stabilized in the services that they need. So I think this goes back to that point of really identifying how and where those referral pathways are and what that launch point is, and that trigger point is, I guess you could say, for an ECM referral. Because the other benefit of ECM is that um, families and children may be concerned about engaging with, a child welfare worker just because of the stigma around that. But since ECM is its own separate program, they might be inclined to engage a little bit more and align themselves with the lead care manager's recommendations. But I think this is a really great opportunity for ECM to support because of all of the services and care coordination opportunities that are available. I think it just goes back to, again, that trigger point for how can we ensure that the providers that are engaging with these families from the beginning have access and education to be able to refer them appropriately. I hope that answers the question a little bit. And yeah, I just saw your follow-up message, which was exactly what I was thinking too, around just fear of surveillance and loss of control. ECM being that support outside of that system that's completely separate could potentially help with that. I see a question. I had an interaction with an ECM provider yesterday who stated that ECM services can be provided until the child are up to 26. Yes, so the age requirements for ECM for children and youth populations, they consider adults up to 21, but if they're in foster care or child welfare involved systems, it's up to 26. That does not necessarily mean, though, that the family cannot receive services after the child turns or individual turns 26. there's two pathways. So the first is if the youth qualifies for an adult population of focus for CalAIM, they could transition into that and still receive ECM. And ECM is also for the whole family. So we've had cases where the youth comes to us, they're 3 years old perhaps, and they're in the care of their grandmother. And grandma also has Medi-Cal managed care plan and also has some maybe unmanaged health needs, complex care needs that she needs support with. We can also open up CalAIM services for grandma with the same lead care manager, and they can support the entire family. So once that child or youth ages out, that doesn't necessarily mean end of services for the family. It might just mean reassessment to see what other populations of focus could potentially qualify them to continue receiving ECM services. Yeah, no problem.
Right. And do you mind, if you feel comfortable, maybe putting the link to a website or your email address or both, so that if people have
Yes,
follow-up questions? Yeah.
for sure. So I'll drop our website here, and I'll put my email in the chat. And I'm still, George, if you can give me like 3 more minutes after this is over to collect all the emails, that would be amazing.
Yeah, no worries.
Just so I can ensure I follow up with people appropriately. But I do appreciate everyone's time and discussion today on this topic. It's really refreshing to have a group that um, is really engaged and wants to talk about this piece because it's such an important component of our work.
Right. And
Thank you,
then
everyone. Thank you so much.